First of all, I would like to congratulate all the three speakers for their excellent and interesting presentation of such difficult topics. I am sure such topics if presented in pediatric conferences would not have attracted this much response from the audience. I also thank the audience for their patient listening. The first question goes to Dr. Sivan. Sir, how long we can wait for if the patient is in subclinical hypothyroidism? For example, the patient remains in for about 2 or 3 years. Can we patiently wait or should we treat? For example, a 3-year-old child having a TSH of between 4 and 10 for about 2 years or more. Can we patiently wait?
Yes, if it is 5 to 10 and there are no symptoms and no goiter, no antibody, yearly once follow-up is sufficient for the first 2 years. And if the TSH is remaining stable, the recommendation is just follow up clinically. If there is any fall in height, growth velocity or any goiter, then you can check. Otherwise, just a clinical follow-up.
The patient is asymptomatic, we can wait.
Yes. Okay. The TSH is progressively rising or in new symptoms, you can choose to treat.
There is a developmental delay, sir, regarding brain cognition. So usually they come, it's a bit delayed whenever there's some subclinical hypothyroidism that for between 5 to 10.
Any gross,
we should intervene or we can give some low dose thyroxine or something like that.
Any gross developmental delay, usually the mild elevation TSH is not the explanation for that gross developmental delay. So look for other causes and you may choose to treat, but don't expect that treating is going to improve the developmental delay. For the benefit of doubt, you may choose to treat, but any gross developmental delay, usually this is not the cause for the developmental delay.
So the report 10 is for all the lab, you can take it, or is there any difference of labs, standardized one? Because some lab they give more than 10 also then they put normal value of 20 to 30 lakh. So yeah, how to interpret this?
Yeah, the reference range, especially the upper limit is different for different labs. Some value the upper limit is 4.5 or 5, but more than 10 we can take any lab. If the TSH is more than 10, then you can choose to treat, either it is adult or children.
Always hypothyroidism, always think about newborn. So if the borderline in the newborn, how long we can wait? Suppose I'm doing it on the 5th day, it comes around 7.5 to 10. So I don't know how long to wait for the repeat the specimen, or we can start treatment and all that. For
neonatal screening, the first 3-4 days, the upper limit can be high. It can be as high as 20 to 25. If after 1 month the TSH is between 5 to 10, then again there is no consensus, because the first 3 years the brain development is critically dependent upon thyroxine. You can choose to treat, or you can keep follow up the patient also.
Especially the small for gestation babies, like preterm or term for small, how long to wait? Suppose the value comes around 10 to 15. Because there we have a dilemma. If we go by the epiphysis, absent epiphysis or femoral epiphysis in a term baby, we take it as congenital hypothyroidism. But in premature, less than born before 36 weeks, I ideally want to follow them for any evidence of hypothyroidism, how to go.
That's what, if it is 5 to 10 and the child has symptoms, you can treat. Otherwise, most of the problems are not related to this TSH. So you look for other causes and follow the patient once a year.
Just in addition to what Dr. Sivan has said, just a small comment. In preterm, that's what you asked. There are gestational age specific TSH nomograms which are derived, but the reliability in Indian setting is, again, more studies are required. So the best answer is you have to wait for the term age, till the baby is of the term age. And when in doubt, I'm sure at that age you won't have big symptoms and all coming up unless there is a severe prolonged jaundice or some other you have an issue. So it's a purely clinical decision, and higher this is relatively sick baby. In sick preterm is generally not the normal healthy thing. So if the preterm baby's TSH is above 10, it is much more pathological than a term baby's value between 5 to 10. So that's the general thing. The ICMR cutoffs for term babies are very clear. For preterm, more studies are required. term, purely I leave it to the neonatal people and use your biological logic on a given patient. Term babies above 10 is highly suspicious, and you have to, as early as possible, reconfirm on a venous sample. If the first one was done on a heel prick, the second one should be preferably in a good lab.
I'll ask one more question. Dr. Mahadevan. Suppose it's a newborn born with no testes. Suppose do ultrasound, everything, could not find the testes at all. How to go proceed then?
First of all, ultrasound also will not pick up a testis. We have had several occasions, at least 7 or 10 times in the last few years, where ultrasound also, if not, I'm sure it's done by a best of pediatric sonologist who is very well versed with identifying in all this. Still, it can descend. You will be in the inguinal canal as small as a pepper size or patani size, and it will be. That's one answer. But if there is no Mullerian structure, the first thing we are looking in the ultrasound is obviously gonad, whether it is traceable. Second is Mullerian structure or not. If there is no, Mullerian structures are clearly present, that means uterus. In the first 6 weeks, under the influence of the maternal hormones as well as the female, the child's gonad, the ovary will show a lot of follicles. The Mullerian structure will be clearly seen by a good sonologist. So, if it is Mullerian structures are present and no gonads are traceable, the DD will go towards dysgenetic forms of sexual differentiation. If Mullerian structures are not present, gonad is not visible, then you have to, that's a very tricky situation where I will follow up the baby. This could be still a male with the testis not being identified, or whether it is female. Then the ovaries, where are the ovaries? Why the Mullerian structures are not seen have to be answered. This is a very tricky situation. I would like to revise the biochemistry. That's not an easy answer to give. The second. First choice is easy to do.
So one more question to...
Sir.
Yeah, I must first congratulate all the speakers for the excellent lucid presentation. Now, the pediatric age group monitoring of thyroid function is quite complex, and the values also change from the neonate to the adolescent, and all these values change, and preterm to term baby. Now, very important is that whenever you have a subclinical hypothyroidism, you must also go into the other features, especially clinical examination, and also the ultrasound is very important. Ultrasound of the neck and also the antibody titers. I have seen many conditions where a lingual thyroid disease or a cryptohypothyroidism or ectopic hypothyroidism, where this TSH is subclinical. Now, whenever the thyroid is not in that location, the subsequent function will almost decrease. And these patients must be monitored, and that must be treated. That is one area. And also in autoimmune thyroid disease, it may be slowly progressive. So in our settings, if we just leave that child, they won't come back again. So in those cases also, we need to treat that patients. The third thing, in pediatric age group, the common problem is most of the children, they get up very late, they take the tablets and they take the food. So there must be a gap between the food consumption and the thyroxine dose, because many times you find with adequate dosing itself, the TSH will be still raised. So you must think of the other causes like food intake and other medications, and that will be the reason for the elevated TSH. So don't go on increasing the thyroxine replacement, see for the other causes. That's very important. Regarding Dr. Sriram Mahadevan, as I earlier, I've seen that in ambiguous genitalia, one important examination is per-rectal examination. Per-rectal examination must be done in all ambiguous child. And the three important tests that is quite useful is estimation of serum 17-OHP, ultrasound of the pelvis, and karyotype. These are three important investigations, the basic investigation which will throw much light. The third speaker, I've seen many obese girls, they come up with features suggestive of a premature talaq. So you must be very careful because they have lipomastia. They don't have breast development. So in those conditions, they will have a normal bone age, but they will be obese. Many times they are treated for it, premature talaq. That's very important.
Regarding the collection of sample, you said TSH is falls elevated in the timing of the sample and the diet. Can you explain something about that?
In general, we don't insist on a fasting sample for routine thyroid screening, but there can be minor variations, especially with food. Generally, some of the studies show that TSH decreases after immediate if you check it after food. So any minor variations, the next time you do it in a fasting sample. Routinely, fasting is not necessary, but there can be minor variations, especially with food. So if you are planning to repeat the test another day, at the time you can choose to check it on a fasting morning time.
One question on the disordered sexual development topic. Now, see, in the Western world, the disordered sexual development, the ambiguous genitalia is a social emergency, and most of the baseline investigations to decide on the actual sex and the sex of rearing will be decided within the first 6 to 7 days of life, and all the information will be available because the registration of the child, whether it's a male or a female, has to happen very quickly there. Now, but in places like, where in India, where there is, lack of pediatric endocrine facility in smaller towns like Salem and things, because the turnaround time for your SRY gene and all those things are quite, and we have to outsource the samples. We don't have a local pediatric endocrinologist, so we have some difficulty in organizing these things. What advice, what basic thing to say, to the parents in the first few days of life regarding, we can't be sending all the patients to Chennai or Bangalore for full workup.
Yeah, I think if I got your question right,
the cost and the turnaround time.
I understand. But,
is there any?
But what, though I have not worked in Western world for too long, but I know that it's surprising that what we read from literature and what you are saying is slightly different in the sense, first thing is to not hurry. Except for the emergency medical treatment which we discussed. Rule, as sir said, you do a 17 OHP or a cortisol and electrolytes, and if the child's general condition is not deteriorating, not going, that means that the child is not having that classic salt wasting kind of CH, at least in a particular. Before the clinical examination will give you a lot of clues on whether this could be CH. So in all other situations, I have faced quite a few of these situations. Let me share one or two experiences which we have. You have to spend a lot of, even several minutes to hours, 1 or 2 hours on different days explaining to the parents as to do not register now. A very, very difficult process. I have written at least on 3-4 patients in Corporation of Chennai. Today you have to give even the name to register, if I am not mistaken. So it's a very, very difficult proposition explaining to the patient. We very easily say in these kind of scientific forums, don't declare, we will discuss later. To the extent that I didn't have time to discuss the last half of how the Western world is actually changing towards, who are you to decide what sex of rearing should be there? The child will decide on its own when the child enters adolescence. The child's rearing should be appropriate. There are many, the Intersex Society of North America is a society mainly run by the people, the children who had ambiguity, and they are now adults. And they are now giving guidelines on how they should be managed to the pediatricians and pediatric. What they are saying is, you unnecessarily mutilated me. Like for example, in a typical male-oriented, very sorry to say that still even today there is a problem. Every ambiguity child's parents, if at all you say that this child may not procreate, this child will have a problem maybe in the future, they will say, you know the social advantages they have in our society. But he will be an infertile fellow, impotent fellow for all whatever reason. That has to be explained. But suppose he says after, why did you rate me as a male? I would have been better as a female. This is what that's what I wanted. The last 4 or 5 slides are on that only. John Money was proposing that he was a pediatric surgeon oriented person. Typically, if the phallus is good and if the urethra can be pulled up, and you can, that's the idea of male thing, no? But it's very easy for a surgeon to convert a male into a female, because creating a vagina and clitoroplasty is much more easier. You talk to, I'm sure there are surgeons, if all they'll share with me, agree with me that that's the thing. So my answer for your question in short is, even in India, whatever practically we faced is, if you talk and counsel repeatedly, you can buy time. You can get exceptions. We have had several occasions. We didn't give the name. But there is a lot of problem. That parent had a lot of problem. The corporation is repeatedly saying we had to reassign a sex after 1 year in a child. Initially, it was registered on a particular name, male sex. Then we had to go back to the diagnosis and convert it into a female. It's a big thing, no? You look from a corporation angle, they will be worried as to why this is changing now. But all these can be tackled in our situation also. Don't hurry for a thing. First of all, we should be convinced what is happening and give the approach as much as possible. Illiterate patient romba kashtam, I agree, but we have to talk repeatedly. So neenga sonna mari oru vaarathukkulla mudiyave mudiyadhu. It is impossible. Karyotyping, fish will come in 3 days. Your hormones will come in at least 2 to 3 days. You can come to some reasonable conclusion. But please remember, many of these tests have to be repeated on another day. All my endocrine friends here will agree with me. You can't have one value in a patient sometimes. And all the tests should be done. One more take-home message for all pediatricians here is, surgeons கூட இந்த மாதிரி சொல்லிடுறாங்க, குழந்தை வளர்ந்த அப்புறம் பார்த்துக்கலாம், 9 மாதம் 1 வருஷத்துக்கு அப்புறம் வெயிட் எல்லாம் நல்லா போடட்டும், அப்புறம் நம்ம இதெல்லாம் பார்த்துக்கலாம். ஸோ hypospadias or any such male ambiguity child, the mini puberty is the first 3 months. Certain tests and the reliability of certain tests are very high in the first 6 weeks of birth. So please do not miss that golden opportunity of first 2 to 3 months. Please repeat tests or talk to. So நீங்கள் சொன்ன மாதிரி நீங்கள் எப்படியாவது இப்போ போயிட்டு வந்துருங்க, 6 மாதம் கழிச்சு போக முடியாதுன்னு நீங்கள் சொல்லலாம் உங்கள் குழந்தைக்கு. சேலம்லேருந்து சென்னை வர முடியல, நம்ம சேலம்லேயே பிரேம் இருக்கார். There are so many people. I'm just saying there are enough people in Tamil Nadu and all. There are no more than 70 endocrinologists somewhere. Endocrinologists only illa. Wherever you are comfortable, at least once they should go if you don't have the facility. Or today in the era of transport, samples can be transported and discussed. I hope there are some good forums where such discussions can happen. But we should not come to a premature conclusion. This answer, dichotomous male or female, cannot be decided on 1 week. Quick, fixed solution cannot happen. That's what is the answer.
Okay, due to what of time, I think we can stop the discussion because the next proceedings are getting late. I thank you all the speakers who gave a wonderful presentation for this. So you can discuss during a tea break, and any further questions can be discussed. Thank you very much.
Thank you so much for such a great session. So it's time to felicitate the speakers and the chairperson. I would like to request Dr. Sendil, Dr. Kumaravel to felicitate Dr. Shivan Arul Selvan by presenting a memento. Dr. R. Ramalingam to present a memento to Dr. Sriram Mahadevan. Dr. Sambat to present the memento to Dr. Sambit Das. May I request Dr. Manigandan to present the memento to the chairpersons. Dr. Kumaravel, Dr. R. Ramalingam. And Dr. Sampath. Thank you so much, doctors.